over to you.
Thank you, Sri Priya. We'll be discussing about the WHO ladder in this session. I'd like to introduce our eminent speaker for the day, Professor Mary Abraham. She's a neuroanesthesiologist and a pain and palliative care specialist. She's currently working as a visiting consultant in Max Hospital, New Delhi, Max Institute of Cancer Care in Lajpat Nagar, Indian Spinal Injury Center in New Delhi, and a she runs a private clinic in Vasant Kunj, New Delhi as well. We have already gone through the introduction, but since it's so impressive, I'm going to repeat the whole thing. So she was awarded the Lifetime Achievement Award by the Delhi Neurological Association for contribution to neurosciences in Delhi in February 2017. Her main interests are in neuroanesthesia and pain and palliative care. She's also authored a book titled Conquering Pain in 2019. Since we already have our at time, we'll over to you, ma'am, to conduct the session. Thank you very much.
Thank you, Shri Priya and Ashok, for that kind introduction. And as usual, it is a privilege for me to take this session. And this time I'll be focusing on, I think last time we had done introduction of pain, if I'm not mistaken, for the same audience, right? Okay, so let's move on to the pain management, in which we will talk about the WHO step 1 and step 2, that's a non-opioids. I'll also touch about the neuropathic pain. Shri Priya, I would like to share the screen.
Yes,
Can I do it?
Sure, ma'am.
Okay. So I think this is the one. So this is okay now? This is the one, right? Okay, let me just start off my presentation. I will be, like I said, the broad outline of my talk will be on the basics of the WHO analgesic ladder, focusing on whatever I've just mentioned right now. So the WHO analgesic ladder was based on the recommendations of a group of international experts, which met first in 81 in Italy, then subsequently in Geneva, and ultimately in 1986, they devised the ladder, the step ladder approach to manage cancer pain. And this ladder has subsequently been translated into 22 languages and has served as a catalyst for treating cancer pain worldwide. Now, it is a very simple and well-validated and effective tool for cancer pain management, and it is based on the severity of pain. Now, prior to the ladder, that is prior to the 80s, people were dying with unnecessary pain for many reasons. First of all is because there was a lot of drug regulations associated with the use of opioids. It was very difficult for institutions to keep these opioids, to dispense them, and even for the people to procure them. It was very difficult because of all the regulations that were associated with the use of opioids. The other reason was that there was a lot of stigma associated with prescribing and taking opioids. And people felt that, that they are addicts, the ones who are taking opioids. So because of that, even relatives are very hesitant to give opioids to their relatives. They were afraid of taking it themselves, wondering whether this is there'll be misuse or abuse of opioids. But when the WHO itself made this ladder, it virtually legitimized the use of opioids, because the step 3 comprised of strong opioids. So in a way, it legitimized the use of opioids for management of pain. Now, when you want to use a ladder, you need to first, since it's based on the severity of pain, we need to assess the pain. So that is what is called a comprehensive assessment of pain, for which there are various, there's a mnemonic called PQRSTU, by which we can assess the pain. And then based on the severity or the intensity of pain, you can apply the ladder. The other important thing we need to know is, what is the kind of pain that the patient is having? Is it nociceptive or neuropathic or a combination of the two? Based on that, you can give whatever drug you want to give, whether it is the adjuvant drug or whether it is the analgesic drug. Now, let me start with the case scenario. A 35-year-old father of 2 young kids. He had squamous cell carcinoma in the upper lobe, right upper lobe. And the pain was a deep-seated gnawing pain. It was localized to the right suprascapular and infraclavicular areas. He was unable to sleep. The pain score was mild. It was around NRS 2 during the daytime, but at night it went up to 4. Okay, so we will discuss how we manage this case at the end of the presentation. Now, the WHO analgesic ladder is a 3-step ladder. The original ladder, which most of us are following, is a 3-step ladder. And this is based on the intensity of pain, right? In step 1, which is mild pain, which is a NRS score of less than 4, for that, we give a non-opioid analgesic with or without an adjuvant, depending upon whether the patient has associated symptoms or not. So if the pain is controlled with this, we can stick to this. But if it is not controlled, and the pain is more severe in a range of, say, about 5 to 7, you call it moderate pain, in which case you add, instead of you add a weak opioid to the non-opioid along with an adjuvant. So you can give a non-opioid as well with the weak opioid. Again, if this is not controlled with this also, then, or if the pain severity is very severe, like in the scale of more than 7 to 8, that is called severe pain. Or if it's not controlled with step 1 and step 2, then you have to move on to adding a strong opioid. You replace the weak opioid with a strong opioid along with a non-opioid and an adjuvant if necessary. Now, this is a 3-step ladder, and using this ladder, nearly 71 to 76% of cancer pain can get relief. Even severe pain can get relief using this simple step 3 ladder, 3-step ladder. Okay. So, what are the salient features of the WHO ladder? The first important feature is, you just remember there are 3 things, if you can remember, is by mouth, by the ladder, by the cloth. And the rest is individualized to the patient, use of adjuvant drugs, and attention to detail. So by mouth means all these drugs that are used in the ladder are given orally. That's a standard route of administration, even for the strong opioids. Because of that, it is very advantageous in the sense that it can be given by the caregiver, it can even be taken by the patient themselves, or by the nurse who is visiting them at home. So it's very suitable for home care, because all these drugs are given by orally. The other important feature is that it is given by the ladder. So usually the protocol is to start with step 1, depending on the severity of pain, and then you move up the ladder like I mentioned earlier. But sometimes when the pain is very severe, we can start with step 3 also after doing an opioid titration, which will be discussed when you're discussing strong opioids. So that is by the ladder. So you can go from step 1 to step 2 or step 3. Sometimes you can even skip a step and go directly to step 3. The third important characteristic of the ladder is the drugs are given by the clock. By the clock means it is given according to the duration of action of the drug and not on a PRN basis. Because if you allow the pain to appear, that is, if the duration of action or the half-life of the drug is exceeded, there is what is called a breakthrough pain. And so you have peaks and valleys. That is not the idea of pain control. Means it is controlled at less than 3 to 4 or even less throughout the 24 hours. So that causes, the patient is also more comfortable, and this breakthrough pain doesn't occur. So if you give it by the clock, it depends upon the duration of action of that particular analgesic. Like if it is a opioid, like a strong opioid like morphine, then you have to give it every 4 hours. So you tell the patient that this is the time You have to start, say, at 6 o'clock in the morning, then the next drug is at 10, and then at 2, and then at 6, and then at 10. So you have to look at the clock and give the drug and not give it when the pain appears. So that is not the way of giving the drug. The other thing is the drugs are individualized to the patient. So the right dose is the one that relieves the pain. That can vary from patient to patient. For example, one patient can get relief with, say, 30 milligrams morphine, whereas another patient can get relief with maybe 300 mg morphine. So the right dose is the one that relieves the pain. It is not depending upon the, it is not the, it can vary from patient to patient depending upon the type of patient is, whether the patient is an opioid naive patient or has the patient already been on opioids. So all that matters. So it is not the total dose, but it is the point at which the patient is getting complete pain relief. We also have to explain that sometimes even before the duration of action is, that is even before the next dose, you can have what is called a breakthrough pain, in which case you may have to give another dose of that drug. So all that has to be explained the idea is to have complete pain relief throughout the 24 hours. So all that has to be specified to the patient. That is what is called individualized to the patient. It varies from patient to patient, the total dose. Then adjuvant drugs can be added at every step of the ladder, depending upon the type of pain the patient has, or does the patient has any other side effects or any other associated types of pains. And then, most important, attention to detail. Now, the drugs are given keeping the patient's age, the comorbidities, the body weight, and the side effect profile. Everything has to be monitored very carefully, and based on that, you're giving the drug. For example, if a patient has advanced liver disease, then you have to reduce the dose of paracetamol. Okay, or if the patient has kidney disease, then you may have to avoid certain drugs. So it's all depends upon the comorbidities, the body weight. If a patient is elderly person who is emaciated, then you have to, according to the body weight and according to the age, you have to titrate the drug. So it's very important to pay attention to detail while prescribing the WHO analgesic drugs. So what are the advantages of the WHO ladder? First of all, as you have seen, it is a very simple ladder, easily understandable. Even you can explain it to the patients and their caregivers. It is a validated tool, that means it has been proven to be effective. And it is also very cost effective. The drugs of the WHO analgesic ladder, be it paracetamol, be it morphine, be it methadone, the total cost of the drug per day is very, very less. So it is very cost effective and it can easily be given to all countries, even the economically weaker countries. So even in the underdeveloped countries, it can be implemented. It is well suited for home care, like I mentioned, by explaining to the patient about the duration of action and about how it has to be given. It's very well suited for home care. Orally, it's given orally. That's another advantage. And not only cancer pain, it can also be used for any kind of acute pain, whether it's post-operative pain or whether it is pain due to a trauma, or even for non-cancer pain patients, whether it is arthritis of the knee or whether it is a spine issue. Even those patients, you can apply the ladder. Like sometimes I mentioned, you can even modify the ladder, like you can omit step 2. If the patient is in very severe pain, you can go straight away to step 3. And sometimes you may have to add a 4th step, because like I mentioned, around 10 to 15% of patients are not controlled even with the step 3 drug, right? So in which case you may have to add a 4th step. And these are the patients who have difficult pain or intractable pain, in which case you may have to use an intervention. It could be a nerve block, it could be an epidural, it could be a PCA pump, patient-controlled analgesia pump. It can be a neurolytic block, like a celiac plexus block or a superior hypogastric block, or it can be a spinal cord stimulation. They are all very advanced neurointerventional procedures, or an intrathecal opioid pump. Okay, so there are various spinal interventions that can be done and that can be added as a fourth step for those segment of patients who are not responding to the 3 steps. And that is a very small segment. And this modification was in 2000, the modification of the WHO analgesic ladder. Of course, there are even advanced neurosurgical procedures like thalamotomy and cordotomy and things like that. But the risks of those procedures are much more than the benefits of the procedure, and they are generally not done nowadays. Now, let's discuss step 1 drugs. Like I said, this is used to treat mild to moderate pain, and they include paracetamol, non-steroidal anti-inflammatory drugs, which can be combined with an adjuvant drug. So paracetamol or acetaminophen acts by inhibiting the central cyclooxygenase enzyme. It does not have effect on the peripheral cyclooxygenase, and because of that, it has got less side effects as compared to the non-steroidal anti-inflammatory drugs. It has mainly antipyretic and analgesic action. It does not have an anti-inflammatory action. The dose of paracetamol, I think all of you are aware, I don't have to say it, but suffice to say that the daily dose should be less than 4 grams and the single dose should not exceed 1 gram. Generally, we give it in a dose of 650 mg every 6 hours because that is the half-life of paracetamol. It has a potential for hepatotoxicity, but it is not absolutely contraindicated in patients with liver disease, and you can give it these patients in the dose of up to 2 to 3 grams a day. It is safe for pediatric use in a dose of 15 mg per kg every 6 hours. Toxicity occurs when you give it more than 90 mg per kg per day. Sometimes when the patients are not tolerating orally, you can give IV paracetamol infusion also, 1 gram every 6 hours. And if the oral route is not feasible, for example, if a patient has oral ulcers or the patient has a head and neck cancer, then we may have to even resort to the rectal route as well. Now, the numbers needed to treat of paracetamol. What is numbers needed to treat, or NNT? NNT is the number of patients who receive the drug for one to have 50% pain relief over the next 6 hours. So, in case of paracetamol, the NNT is 5. That means for every 5 patients who give paracetamol, 1 patient will have pain relief. So it is not a very good analgesic from that point of view, but still it is a fairly good analgesic. Now, what are the advantages of paracetamol? Like I said, it has a very good safety profile because it does not act on the peripheral cyclooxygenase enzymes. It has no adverse effects on the gastric mucosa. It is well tolerated by patients with peptic ulcer. It has no adverse renal effects, no effect on platelet function and aggregation. It is tolerated by 2/3 of patients who are hypersensitive to aspirin and who have allergies, and it does not affect the plasma uric acid levels. But there are certain drawbacks of paracetamol, and that is the increased frequency of administration. That its half-life is 6 hours, so you have to give it every 6 hours. It does not have an anti-inflammatory action, and it has the potential for hepatotoxicity, particularly when you're giving it in a high dose, those with impaired liver function and those who are taking alcohol of more than 3 drinks a day. And if the body weight is less than 50 kilograms, then you must restrict the dose to 2 grams. That is 500 mg QID or PID. So the role of paracetamol in cancer pain, it is a mainstay drug of the WHO analgesic ladder. I said it can be given at every step of the ladder. It has a good safety profile. It also has an opioid sparing effect. Because when you add it with an opioid, whether it's a weak opioid or a strong opioid, you can actually decrease the dose of opioid that you're giving. And secondly, it can also be added to the step 1 and step 2 and step 3 drugs. It actually improves the NNT. So it can be given at every step of the ladder. So now we move on to the non-steroidal anti-inflammatory drugs. Like I mentioned, this acts by inhibiting the peripheral cyclooxygenase enzyme. This is a very important step in the arachidonic acid cascade, which produces tissue and inflammatory prostaglandins after tissue injury is happening. Whether the tissue injury is because of the cancer process or whether it's because of a trauma or a post-operative thing, irrespective of that. Now, prostaglandins are important intermediaries in the mediating pain and inflammation, and it acts through peripheral sensitization. So these drugs are particularly useful in nociceptive pain, that is pain due to tissue injury associated with inflammation. I had mentioned this chart in my previous talk with you people, in which I can tell about how tissue damage leads to, the cyclooxygenase enzyme acts here and produces the inflammatory mediators like prostaglandins, bradykinin, serotonin, etc. And they form a sensitizing soup around the nociceptor, which increases its excitability and irritability, leading to an amplification of the pain signal. So this is a diagrammatic representation of the same, in which you have the nerve ending or the nociceptor, the peripheral nerve ending, and the first order neuron. And you have that this is a tissue, damaged tissue, and all these mediators, the inflammatory mediators and the excitatory mediators are there around this, forming the soup, which leads to the peripheral sensitization. And it is these COX inhibitors, that is a COX-2 inhibitors, act at this level by preventing the production of the prostaglandins. So if you look at it, again the same thing, tissue injury, phospholipids, which leads to arachidonic acid production, and the COX-2 enzyme occurs. It is induced after tissue injury. It is not present before that. Tissue injury causes the release of COX-2, which produces prostaglandins and inflammation. But there's another COX enzyme, which is called the COX-1, which is present in normal tissues. And this is called the constitutive or the housekeeping enzyme. And this is the one that mediates normal homeostatic functions or the physiological responses, like it protects the stomach and the kidney and facilitates platelet aggregation. So this is present normally, whereas this is produced only when there is inflammation. So non-steroidal anti-inflammatory drugs are of two types. One is the non-selective NSAIDs, which interferes both with the COX-1 and the COX-2. Whereas you also have the selective COX-2 enzyme, which interferes only with COX-2 and does not interfere with the function of COX-1. So it preserves the homeostatic function. It only has the anti-inflammatory function. So the non-selective NSAIDs, the prototypes are ibuprofen, naproxen, aspirin, etc. They inhibit, because they're non-selective, they inhibit the COX-1 as well as the COX-2. By inhibiting the COX-1, it actually produces the adverse effect, the GI side effects, the hypersensitivity, and the adverse renal effects, because it is inhibiting the physiological function of these COX-1 enzyme. But by inhibiting the COX-2, it is actually being anti-inflammatory and it decreases the inflammatory mediator production. So it exerts its anti-inflammatory, analgesic, and antipyretic effects. So non-selective NSAIDs is actually a double-edged sword with both adverse as well as beneficial effects. So like I said, the prototypes are ibuprofen. It's given orally in a dose of 400 mg every 6 to 8 hours. Its NNT is 2. That means it's a good analgesic. For every 2 people, you can get 1 person will have good adequate pain relief. Naproxen, another one, it has NNTs 2.7. It's given in a dose of 250 to 500 mg twice daily, orally or as a suppository. Now, the side effects of non-selective NSAIDs, it's resulting because of the COX-1 inhibition. And so it can have adverse cardiovascular effects, adverse renal effects, adverse gastrointestinal effects like bleeding and ulceration. It can also cause allergic manifestations related to the respiratory tract, skin, or generalized allergic reactions. Now, coming to the selective COX-2 inhibitors, like I said, they are not inhibiting COX-1. So the physiological responses are maintained. That is the effect on the stomach mucosa and on the platelet function and on the renal function. That is maintained. It is only inhibiting the COX-2 enzyme. The drugs that are the selective COX-2 inhibitors are etoricoxib, like or Nucoxia, in a dose of 60, 90, or 120 mg once daily. or celecoxib in a dose of 100 to 200 mg twice daily. Diclofenac sodium can be given orally or IV, and its NNT is also very good. It's 2. That means for every 2 patients who are given this drug, 1 will have good relief. So it is a good analgesic. It also comes under the category of selective COX-2 inhibition. Now, NSAIDs can also be given topically, like we are all aware. So it produces analgesic effect with less risk of systemic absorption and toxicity. And some of the creams and gels are available contain ibuprofen, diclofenac, piroxicam, ketoprofen, etc. are used for pain management. Now, are selective COX-2 inhibitors safe as compared to non-selective COX inhibitors? Now, where the GIT is concerned, it is comparable to non-selective NSAIDs, but where renal damage is concerned, it's not superior to the non-selective NSAIDs. On the other hand, it has a prothrombotic effect. The COX-2 inhibitors can have a prothrombotic effect, and there is more likelihood of myocardial infarction and stroke, especially in patients who have got atherosclerotic disease. In fact, the rofecoxib, which was a selective COX-2 inhibitor, was taken off the US market in 2004 because of these adverse effects. So in such patients, if you need to give NSAIDs, it is safer to give brufen and naproxen in the high-risk cardiac patient. So what are the risk factors for NSAIDs toxicity? For GI toxicity, patients with history of upper GI symptoms, or those who have bleeds, or when you want to give it for prolonged use, you avoid non-selective NSAIDs. And similarly, for renal toxicity, ensure the patient is adequately hydrated. Dehydration can worsen the situation. And also, when the creatinine clearance is low or advanced stage, etc., avoid the use of NSAIDs, non-selective NSAIDs. And like I mentioned, COX-2 inhibitors should be avoided in patients who have risk factors for stroke or MI, like those with hypertension, diabetes, hyperlipidemia, smoking, or previous history of TI or stroke. You can avoid COX-2, and in such cases, it is safer to use either brufen or naproxen, or maybe you may have to stick to the paracetamol or drugs like that. Now, coming to the step 2 drugs, they are the weak opioids. So they are not controlled. That means they are not more easily available, and so they are very widely used. It is given for pain of moderate intensity, which is not controlled with step 1 drug. And the examples that are common use are tramadol and tapentadol. So if you look at the weak opioids, they are the centrally acting. They have a dual method of action because they are a weak opioid. So they act on the mu opioid. They are an agonist of the mu receptor. And that is how they have the weak opioid effect. And because it's a weak opioid, it has less tendency for respiratory depression and addiction potential as compared to the strong opioids. But besides the effect on the opioid receptors, it also has an effect on the reuptake of serotonin and norepinephrine. So they actually activate the descending inhibitory pathway of pain. Like pain, I mean, if you know the pathway of pain, the ascending pathway is the one that is going and to the brain, and it is perceiving pain. But there are descending pathways also. And these descending pathways can be either facilitative or inhibitory. The inhibitory descending pathways actually will prevent the pain impulse from ascending upwards. And that is because of the mediation of the serotonin and norepinephrine. And these weak opioids actually block the reuptake of serotonin and norepinephrine and increase its levels. And that is how it acts on the descending inhibitory pathway. And because of this very reason, it is also effective for neuropathic pain, because in neuropathic pain, this pathway is the one that is. Now, sometimes you can combine paracetamol with tramadol also as a step 2 drug, which is widely used in practice. Now, coming to tramadol. Tramadol is widely used. It is got high oral bioavailability. The oral dose is very potent. It's 1/10 as potent as morphine. That means if you're giving 400 mg tramadol, it's equivalent to 40 mg morphine. And the dose is generally 50 to 100 mg every 4 to 6 hours, the maximum dose up to 400 mg. Sustained release formulations are also available that can be given twice daily. But it has some side effects, and some patients get nausea, vomiting, dry mouth, constipation, dizziness, sedation. And also those who have history of epilepsy, and they can, because it lowers the seizure threshold, you have to use very cautiously in these people. The other weak opioid is tapentadol. It is very similar to tramadol. It is a newer drug, and its method of action is also similar. It acts at the mu receptor as well as it acts on the descending inhibitory pain pathway. But its side effect profile could be better than tramadol. The dose is also very similar to tramadol. So if you look at some of the analgesic combinations, we should never combine a COX-1 and COX-2 inhibitor. Okay, that is one analgesic combination that is not logical, actually. Similarly, we should not combine a weak opioid with a strong opioid. So a patient who's taking morphine, there's no need to add a tramadol to them. But the combinations that are favorable are when you add paracetamol with an NSAIDs, or paracetamol with tramadol, or paracetamol with a strong opioid, or NSAID with a strong opioid. So they potentiate the action of the other drug and can have an opioid sparing effect as well. Having dealt with this basic analgesic ladder, let us go on to neuropathic pain and the role of adjuvant drugs. Like you all are oncologists, so you all know that besides nociceptive pain, that is pain due to tissue injury, there are various other factors that cause pain. It could be muscle spasm, it could be the neuropathic pain because of nerve involvement, it could be bone pain or bowel obstruction pain, or there may be associated symptoms as well. So this is where the role of adjuvant drugs comes into the forefront. So adjuvant drugs are, primary indication is not for pain. For example, an antidepressant is used for depression, or an anticonvulsant is used to treat convulsions. So the primary indication is not pain, but they have analgesic properties, and hence they're called co-analgesics because they are co-administered with the analgesics of the WHO analgesic ladder. They can be multi-purpose or specific adjuvants. Specific adjuvants are those that are given to treat specific types of pain, like it may be a neuropathic pain or a bone pain or musculoskeletal pain or a bowel obstruction pain. Whereas multi-purpose adjuvant drugs can be given with a large umbrella of pain issues, like antidepressants, corticosteroids, or sedatives or antispasmodics. They can be given for a variety of pain associated with cancer. That is why they are called multi-purpose adjuvant drugs. Now, we are all aware that neuropathic pain can occur in up to 40% of patients with cancer. And this neuropathic component has got a typical quality which differentiates it from nociceptive pain. The pain is usually dysesthetic, with it could be allodynia, it could be shooting or electric current. So that is how, or a burning kind of pain. That is how you distinguish that this patient has a neuropathic pain. So if you look at the pain pathway, this is the tissue injury that is occurring at the periphery, and this is what causes the nociceptive pain. Anything beyond this, the peripheral nerve and in the spinal cord or in the brain, it comes under neuropathic pain. So the definition of neuropathic pain is it is caused by a disease or a lesion in the peripheral or the central nervous system. Sometimes the pain can be mixed. It can have both a nociceptive as well as a neuropathic component. Why does it occur, neuropathic pain? We are all aware, and you are all aware, that it could be because of either the direct invasion of the nerve because of the tumor, or maybe the compression of the nerve as well, or it could be because the treatment of cancer. Like, for example, you have a chemotherapy-induced peripheral neuropathy or radiation-induced peripheral neuropathy, or it could be because of the surgical excision where there could be injury to the nerve, and sometimes it even occurs in cancer survivors where it can persist for months or years after the patient is even cured of cancer. The most commonly used drugs in neuropathic pain are the anticonvulsants, antidepressants, or even you can give drugs like the step 3 drugs like methadone, morphine, and the step 2 drugs as well. And the less commonly drugs are the local anesthetics and MDA inhibitors. There's a neuropathic pain ladder as well. This is in the step 1, you give either an antidepressant or an anti-epileptic. In step 2, you combine the two, antidepressant and an anti-epileptic. In step 3, you can go on to an NMDA antagonist. And in step 4, you can go to a local anesthetic. But this is a very rough way of calculating. Ultimately, it all depends upon the patient. This is just a simple framework by which you can go by. Anticonvulsants, we know that it is one of the first line of treatment of neuropathic pain. Why are they used in neuropathic pain? Why are anticonvulsants used? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitability. So these drugs act by depressing or dampening the neuronal hyperexcitability, and the commonly used drugs that we'll be discussing later. How do they act? These drugs act by binding to the voltage-gated calcium channels, particularly the alpha-2 subunit of the calcium channel in the presynaptic neuron, by which it prevents the influx of calcium into the presynaptic neuron and consequently the release of these excitatory neurotransmitter to the synaptic left and ultimately exciting the postsynaptic neuron. These excitatory neurotransmitters could be glutamate, aspartate, etc. So the drugs that are used are gabapentin and pregabalin. They have got a generally good profile in which they can have got proven effect in neuropathic pain with good tolerability. The side effects we should keep in mind has to be told to the patient about the increased somnolence, dizziness, ataxia, etc., and even weight gain also. The antidepressant drugs I mentioned are the first line of treatment for neuropathic pain. Its onset of action generally takes a week or two, and they occur earlier and at lower doses as compared to the antidepressant effect of these drugs. But because many cancer patients have depression, anxiety, insomnia, they're very useful to add to their treatment regimen. How do they act? I mentioned they act by inhibiting the reuptake of norepinephrine and serotonin and thus activating the descending inhibitory pathway of pain. There are two types of antidepressants we can give. One is a tricyclic antidepressant, which is either amitriptyline or nortriptyline. Then you can have the SNRI, that is a serotonin norepinephrine receptor inhibitor. The drugs that are commonly used are duloxetine and venlafaxine. And then you have the selective serotonin receptor inhibitor, that is the SSRI. They include escitalopram, citalopram, paroxetine, etc. But this SSRI have more effect on anxiety and depression as compared to the pain. So it is the first two categories that are more effective for pain. So if you look at the analgesic efficacy, the TCA is more efficacious than SNRI, which is more than SSRI. And if you look at the side effect profile, the TCA has got more side effects as compared to the SNRI and the SSRI. But it should be remembered that the tricyclic antidepressants and all antidepressants can have side effects like the CNS side effects, which include somnolence, drowsiness, mental clouding, even suicidal tendencies. It also has anticholinergic or the antimuscarinic effects, which include dry mouth, acute angle glaucoma, which may lead to blurred vision, tachycardia, urinary retention, constipation, and orthostatic hypotension. So these should be explained to the patients before you start on these drugs. So they are contraindicated in patients with cardiac conduction defects, those with prostatic hypertrophy, and those with glaucoma. The dose, amitriptyline, you start in a dose of 10 mg and gradually you step up every 3 to 5 days. Similarly with nortriptyline. Gabapentin also, depending upon the age and the body weight of the patient, we can start with the dose of 100 mg and then step it up. Similarly, with pregabalin, you start with a dose of 75 mg. Just remember, all dosage adjustments should be made in medically ill patients and those with renal dysfunction. The other neuropathic drugs that you can give for neuropathic pain are ketamine, they act by blocking the NMDA receptor. I just see the time. I think I've got another 5 minutes left. I'll just go through that. So this NMDA receptor is present in the dorsal horn of the spinal cord, and this is where drugs like ketamine act by particularly useful in difficult neuropathic pain. It can have side effects, so this can be diminished by giving some psychotomimetic, antipsychotomimetic drugs like haloperidol or benzodiazepine. It can cause hepatotoxicity. Some cases have been reported, so you have to monitor the liver function. And sometimes when it is abused for recreational use, you can even have some vesicopathy symptoms. Ketamine can, like I mentioned, it's an anesthetic drug, but in analgesia for neuropathic pain, you give it in sub-anesthetic doses. So you give it in a dose of 10 to 25 mg TDS. It can also be given as a subcutaneous or intravenous infusion in a dose of 50 to 100 mg a day. Sometimes for difficult pain, it can be given as a burst ketamine infusion that we can discuss in when we're having the session on difficult pain. Local anesthetics, like I said, can also be effective in treating neuropathic pain, particularly when there is a difficult neuropathic pain. But you must remember that they can have they can cause toxicity as well. So you have to be very careful. It can be given as an IV local anesthetic infusion. In a dose of 5 mg per kg over 1 hour, you have to use the Xylocard, which does not have the preservative, but with cardiac monitoring. Local anesthetic patches are also available. 5% lidocaine patches called Lidovelar is also available in India, and that can also be used to treat neuropathic pain. It has been found to be effective in patients with post-herpetic neuralgia who have neuropathic pain. Now, corticosteroids, as mentioned, is a multi-purpose and adjuvant drug. It can be given for a variety of conditions, which include neuropathic pain, bone pain, headache because of intracranial metastasis, for hollow or viscous obstruction, also for spinal metastasis. Dexamethasone is a preferred drug because of its long duration of action. It has to be given only once a day. It has also got less mineralocorticoid. Now, some drugs like baclofen can be used when there is spasticity, and particularly neuropathic pain associated spasticity. And this can one of the useful adjuvant drugs. Bone pain is another cause of very severe agonizing pain. And this is because of the skeletal related events that occur because of metastatic bone disease. And the various drugs that can be used are the corticosteroids and NSAIDs for multifocal bone pain, calcitonin or Gemcal. The latest reviews show that no significant improvement in quality of life, but I think you people are the best judge. Bisphosphonates and denosumabs are very useful for bone pain as it inhibits the osteoclast-mediated bone resorption and reduces the skeletal-related events. And of course, there is palliative radiation as well. So bisphosphonates are useful in treating metastatic bone disease. We are all aware that zoledronic acid is a drug that is usually given. So when you compare zoledronic acid with denosumab, while this is more cost effective, it has to be given intravenously. It is also more risk for renal toxicity. But denosumab, while it's more expensive, it can be given subcutaneous as well, less risk of renal toxicity, although there is more risk of hypocalcemia. It is superior in preventing the skeletal related events, and it has also got a better median survival rate. Then, of course, there is palliative radiation for bone mets. And then there is pain due to bowel obstruction, for which you can use steroids or octreotide or anticholinergic drugs like hyoscine and glycopyrrolate. Sometimes you can use a combination of all three. The other adjuvant drugs that can be used are the skeletal muscle relaxants like thiocolchidoside, like Myoril, tizanidine, chlorzoxazone. Then if the patient has delirium and anxiety and agitation, you can use neuroleptic drugs. Then sometimes you may have to use sedatives if they're not having sleep, or anxiolytics or laxatives. So these are the other adjuvant drugs. Now coming to the case scenario, we mentioned about this young father of 2 kids who has CA of the lung. he had this nociceptive pain. He was unable to sleep, and the pain was in the category of mild pain. So how do you treat it? Now, since the intensity was mild, okay, and the type of pain was basically nociceptive, the temporal nature of pain was it's worse at night as compared to the daytime. And if you unveil the meaning of pain in this patient, it had a lot of functional, emotional, social, and financial aspects also. Possibly because he was a father of 2 young children with financial and social concerns as well. So in such a patient, the type of analgesic that you would choose would be generally the WHO step 1 drug. You can use a combination of paracetamol with NSAIDs, but since the pain was worse at night, you could possibly give a sustained release preparation at night, like a paracetamol 1000 mg or a diclofenac SR or something like that. And since he was not getting sleep, you could add an analgesic. You could add a sedative, and also it was so important to address his psychosocial concerns as well. So in summary, the WHO analgesic ladder is a sheath anchor of cancer pain management. It can be used also for non-cancer pain. The main advantages are its simplicity and easy implementation, and it can be used for domiciliary care as well. And also in the remotest corner of the world, it can be used. And most importantly, it has legitimized the use of opioids in cancer pain and non-cancer pain. So that is my presentation, and I will... Yes.
Thank you, Dr. Shubhi.
So thank you very much, ma'am, for that very lucid presentation. I enjoyed it as much as I did last time when I was in your class. We have another 10 minutes for questions. So if anybody has any questions to ask Professor Miri, please unmute yourself and you can ask her directly.
Ma'am, can I have a question?
Yes, please.
Yeah, Madam, regarding intestinal obstruction, how do you judge morphine in this scenario?
See, morphine has basically it is not a very good drug to give for intestinal obstruction because it can cause closure of the sphincter, right?
Yes.
So
Yes.
morphine is generally not given in intestinal obstruction. But you can add, like I said, the adjuvant drugs like anticholinergic drugs like hyoscine butyl bromide steroid as well as somatostatin anti. But I don't think morphine would be a very good drug to give in such a patient because it can cause a closure of the sphincters.
Ma'am, there's one message from Dr. Ruchir Tandon. Can we omit the night dose of morphine?
On the contrary, we have to give a higher dose of morphine at night. Like, for example, if a patient is taking 5 mg every Q6H, at night you have to give 10 mg because you're giving the next dose only in 6 o'clock in the morning. So you have to give an extra dose of morphine because it has to tide over the whole night. Otherwise, he's likely to get a breakthrough pain. So according to the WHO protocol, this is how we do it, that if you're giving whatever dose you're giving in the daytime, you have to double that dose for the night dose at 10 o'clock so that the next dose at 6 o'clock, till then he'll have pain relief. So instead of avoiding the drug, you actually have to double the dose of drug, and that will be discussed when the strong opioids are being dealt with. So you have to give an extra dose of morphine at night.
There's a question from Dr. Vinayak. I'm not, the question is not clear. We are placing transdermal opioid use. Can you please elaborate, Dr. Vinayak? There's a message in the chat. Dr. Vinayak, can you please explain your question to ma'am?
Can you
transdermal?
hear me?
Yeah. Transdermal opioid use, that is use of fentanyl, right? Or buprenorphine.
Yes. Both, ma'am. How to like switch over? Like I have put on fentanyl for acute thing. slowly I'm switching over to Bular. Is there any ways to do it? As of now, we're doing it very crudely.
See, I know that. If we know how to switch over from morphine to fentanyl because of the equianalgesic dose you have to see, like for example, a patient is getting 25 microgram of fentanyl patch, it is equivalent to 60 mg morphine, right? But for buprenorphine, I'm not aware of how much you have to go. Okay. I don't know whether there is a equianalgesic dose between fentanyl and buprenorphine. I'm not aware of it. But we know how to switch over from oral to fentanyl patch. But I'm not aware of how to go. But generally, we would start with a lower dose of 5 mics per hour, like 2.5 milligram patch, and then go higher than that. I think so.
Yeah,
Because we have to be very careful. Pardon me?
Ma'am, we have great difficulty in this switch, ma'am, because it's long acting buprenorphine.
Yes, it's long acting drug. Yeah.
And this is short acting, and the patients, we want them to go for Bular, the cost and other concerns, but it becomes very difficult to switch from there. We use opioid now, but that side effects of opioid is also bothering.
Yes. But I'll have to look up and see what is equianalgesic dose of, because whenever you're switching over, you have to go to the morphine equivalence and then switch over. It's called oral morphine equivalent, and then you can calculate what is the equianalgesic dose. For that, I'm aware of fentanyl, but for buprenorphine, I'm not aware. Maybe we'll have to check up and see. Maybe when the next session on strong opioids are being done, we could raise this question over there.
Sure. Thank you, ma'am.
Okay. The other question I can see is tramadol 50 mg 6 hourly has many side effects. No? Yeah. So it all depends upon how much the patient can. Is a patient controlled with 50 mg or you have to go up higher? You can give it even 100 mg depending upon the body weight of the patient, right? So you can give it TID also. Or you can give it, if you're giving a sustained release formulation, you can give it twice daily as well. Duration of action is 6 to 8 hours. Duration of action is 6 to 8 hours.
Especially when we are using tramadol in combination with paracetamol, like a good combination to start usually would be paracetamol 650 6th hourly and tramadol 50 mg 8th hourly. It should control most mild to moderate pain.
Yes.
So then we probably can escalate to 100 mg TID if required. Is that right, ma'am?
Yes, that's absolutely right. Yeah.
Okay, thank you, ma'am. Thank you.
And you can try to phase it out. Like ensure that the patient is getting stagger the drugs. Like if you're giving paracetamol now, then give a little later tramadol and then paracetamol. So by staggering it, you're having a better cover of the pain, and you can suppress the pain in the whole 24 hours. So when you make out the dose regime and the timing of the drug, you make sure that it is staggered. All these drugs are staggered over the 24 hours. And you can give a sustained release formulation at night so that whole night is also covered as well.
Are there any more questions from the audience? So, ma'am, you needn't have worried about time. You have not only finished in time, we have 5 minutes left. So if there are no more questions, maybe we can close this session and we can see everyone else next week. I'd like to just remind everyone that there'll be a feedback form sent to you. Please do fill in the forms. It would be very, very useful for us. It gives us a very good idea about how effective the course is and how we can improve. So please do fill in the forms when you get time. And as always, the sessions material will be sent to you by email before the next session starts. So this the session. Thank you very much for joining us, Ms. Sripriya.
Thank you, Dr. Ashok.